retained when it does not come out even after 30 minutes after birth of the baby. Next. So there are three phases involved in normal expulsion of placenta. First, it has to separate through the spongy layer of the decidua. Then it has to descend into the lower segment and vagina. And finally, it has to be expelled to the outside. Next. One slide back, please. One slide back. Yes, you can go ahead, please. So, what happens? What interferes in the physiological process which results in retention of the placenta? So, first is poor voluntary expulsive efforts of the mother, then uterine atony. This is the commonest cause, and it occurs in which type of women? A woman who is a grand multipara, who had over distension of the uterus, such as in cases of twins and hydramnios, then prolonged labor, then uterine malformation, or due to bigger placental surface area. The third cause is morbid adherent placenta, and this can be partial or complete. Then, fourth is placenta incarcerated following partial or complete separation due to constriction ring. Next slide, please. Now, what are the risks of retained placenta? First is hemorrhage. If the placenta is partially separated, there is risk of hemorrhage. And this hemorrhage or infection may lead to shock, and puerperal sepsis also can occur. And there is also a risk of recurrence in the next pregnancy. Next. So how do you manage? So you should wait and watch carefully for evidence of any bleeding and to note the signs of separation of placenta. In the meantime, you can catheterize the bladder so that it becomes empty. The empty bladder is good for taking out the placenta out. Next slide, please. Now, if the placenta is separated, then placenta should be taken out by controlled contraction. If it is unseparated, you have to do manual removal of placenta under general anesthesia. And if it is complicated, then we will let you know what are the ways of getting or overcoming this problem. Next. Now, how do you remove the placenta manually? If once you have decided that you are going for a manual removal of placenta, you have to take the patient to the OT. There, under general anesthesia, you have to give antibiotics and place the woman in lithotomy position. Then what happens? You have to take all aseptic and antiseptic measures, then drape the woman, catheterize the bladder, and then you ask one of your assistants to stand by you. The one hand is introduced in the uterus in a cone-shaped manner, following the cord which is made taut by the other hand, or if the attendant or your assistant can catch hold of it. Next. Now, with one of your hands on the uterine fundus, you have to give counter pressure. As soon as the placental margin is reached, the fingers are insinuated between the placenta and the uterine wall with the back of the hand in contact with the uterine wall, and the placenta is gradually separated with a sideways slicing movement of the fingers until whole of the placenta is separated. Next. When the placenta is completely separated, it is extracted by traction of the cord by the other hand. The uterine hand is still inside the uterus for exploration of the cavity. Intravenous methergin, zero point 0.2 milligram, is given and the uterine hand is gradually removed while massaging the uterus by the external hand to make it hard. Now, once the placenta is out, you have to inspect the cervicovaginal canal to exclude any injury. You also have to inspect the placenta and the membranes to see whether the placenta has come out in totality. Next. Now, what difficulties you can face? Sometimes there is formation of hourglass contraction, and this leads to difficulty in introducing the hand. Administration of any oxytocin, especially ergometrin, in the active management of third stage or undue irritability of the uterus by premature attempts to express the placenta is the important cause. The ring should be made to relax by deepening the plane of anesthesia. Next. Now, the most difficult situation, morbid adherent placenta. In majority of the cases, the diagnosis is made only during attempted manual removal. But on rare occasions, however, no cleavage between the placenta and the uterine wall is possible, and the diagnosis of placenta acreta is certain. The probable cause is due to absence of decidua basalis and poor development of fibrinoid layer. Overall incidence of placenta accreta or its variation is 1 in 550 deliveries. But this thing which I was telling you, morbid adherent placenta, this goes unnoticed only when the woman has not had an antenatal checkup or antenatal care. This is for rural women. Usually the urban woman or women who are under antenatal care, they undergo scan at 18 to 20 weeks gestation, and since then only the diagnosis is made clear that the woman is having a morbidly adherent placenta, and the clinician has to be ready for the delivery of the woman and delivery of the placenta. Keeping in mind placenta accreta, you have to be ready with 4 pints of blood, and the way you have to tackle it, either you have to do a upper segment cesarean and come out, or you can also go after taking out the baby, you can also go for a hysterectomy. Next. So what are the complications of this condition? Hemorrhage, shock, injury to the uterus, infection, inversion, subinvolution, thrombophlebitis, and embolism. Next. So what are the risk factors for placenta accreta? Placenta previa is a risk factor for placenta accreta. Prior cesarean delivery, uterine surgery, DNC, manual removal of placenta, then synechiolisis, myomectomy, increasing maternal age, and parity. Next. So, ultrasound imaging, color Doppler, and MRI have all been valuable in the diagnosis of placenta accreta, increta, or percreta during pregnancy. Ultrasound findings all are valuable in the diagnosis of placenta accreta, and the findings which are suggestive of placenta accreta on ultrasound are loss of normal hypoechoic retroplacental myometrial zone, thinning and disruption of the uterine serosa bladder, then color flow Doppler study interface and fetal exophytic masses invading the shows hypervascularity of serosa bladder interface. MRI reveals it detour vessels and dark intraplacental bands on T2 weighted imaging. Next, next slide, please. Now, unexplained rise of maternal serum alpha fetoprotein is observed with placenta accreta. Then pathological confirmation includes absence of decidua basilis, then absence of Nitabugs fibrinoid layer, and varying degree of penetration of the villi into the muscle bundles or up to the serosal layer. This is known as percreta. And the risks include hemorrhage, shock, infection, and rarely inversion of the uterus. Next slide, please. So, how do you manage placenta accreta? Once you know that the woman is suffering from placenta accreta, a multidisciplinary team approach is a must. In partial placenta accreta, the placental tissue is removed as much as possible, oxytocics are given, and in cesarean delivery, bleeding areas should be staged. If the uterus fails to contract, an early decision of hysterectomy should be taken, and this is preferable in multiparous women. Next. In total placenta accreta, hysterectomy is indicated, and this consists of incising the uterus above the placental attachment and clamping and cutting the umbilical cord as close to its base as possible and leaving behind the placenta, which is expected to be autolyzed in due course of time. You should also give appropriate antibiotics, and any attempt of placental separation puts you in the risk of massive hemorrhage. Next. Next slide. Uterine artery embolization or therapy with methotrexate has been done for conservation of the uterus. In a rare case, placenta accreta may invade the bladder. In that case, try to avoid placental removal, and it may need hysterectomy and partial cystectomy.